I'm going to go ahead and just jump right in. All right, so our objectives for today, prioritize developmentally appropriate holistic nursing care for children with psychosocial and or cognitive conditions, to examine childhood cancer, and to explore grief and caring for the professional caregiver. So lots to talk about today. All right, so let's start with psychosocial and cognitive issues for our pediatric population. So I've picked out some of the more common ones that you guys may have either heard of or have had some experience with, either with your own families or friends. So we'll start off with ADHD, classified as inattentiveness, hyperactivity, and impulsiveness. Very common in childhood and can persist into adulthood. It can be misdiagnosed. It can manifest between the ages of 4 and 18. So that's a pretty broad spectrum. That's a pretty wide range. The next one that I wanted to kind of just touch on was depression. Difficult to detect. It's often overlooked in our school age and adolescent population, but statistics are on the rise for this problem. And part of it is because children have limitations to being able to express how they feel, especially school-age children. Adolescents, they're a little better. They, of course, have that higher ordered cognitive functioning, but when it's something emotional, it can be difficult for them to express. And the findings, they have to be present for at least a year before a definitive diagnosis is given. Okay. All right. So along the lines of depression is suicide. And unfortunately, it does happen with our pediatric population. So I have some statistics here that I'm going to share, and hopefully they kind of express the seriousness of this problem, because as nurses working with families, this is definitely something that we need to be aware of. So suicide rates vary depending on ethnic group. According to the CDC, the rates for males between the ages of 15 and 19 increased from 12 to 18 per 100,000 from 1975 to 1990. So that's an older statistic. Then they dipped a little bit to 10.8 in 2007, but then increased by 31% to 14 per 100,000 in 2015. So the rates are increasing. Okay. Increasing rates of depression in the adolescent population are obviously the contributing factors. But definitely something to be aware of. Rates in the school-age child are on the rise as well. There's lots of reasons that I think you could probably understand and probably are already aware of, because some of you may have school-age children or you may have adolescent children. But nurses need to be on the front lines. We need to be providing that anticipatory guidance to these children and their families, whether it be ADHD, because that can be a problem for kids, right? Because and a lot of times it's not picked up at home. It is picked up when they start school because they just can't pay attention. Maybe they have low scores on their testing, or whatever the case may be. They can't sit still. They get up out of their seat all the time. They're fidgety. They just really are not able to focus and pay attention. But with depression, of course, that is a mental illness, and it's not something that we just want to label somebody with. But part of the reason why this is becoming more of an issue is social media. I can tell you right now, cyberbullying. I mean, it used to be when we were younger, and I'm speaking of myself because I was bullied when I was in school. You go home, you're safe from it, right? You're in your home environment, you're around your family, and you don't have to worry about those bullies getting to you once you get home. Now, kids are constantly surrounded by this toxic communication. And I call it toxic because that's exactly what it is. And there really isn't any getting away from it anymore like there used to be. They're constantly being bombarded with these toxic messages, whether it be Twitter, Facebook, Snapchat, whatever the case may be, whatever social platform there is. These kiddos are getting surrounded constantly. And there is no getting away from it. And it's devastating. It's very devastating. And it leads to depression. It leads to suicide rates. It leads to a lot of emotional issues, traumatic. Some of these kiddos may end up with PTSD type symptoms because of this trauma, of this bullying. It's a very pervasive problem. And I think that there's more awareness out there than what there once was. I think that it used to be just, oh, that's just kids growing up. That's just something that you go through in childhood. And it shouldn't be. It shouldn't be something that you go through or a badge of honor that you get because you made it through your adolescence. It's a serious problem and it needs to be handled like a serious problem. So, and I think that there's more awareness out there, especially from the healthcare workers' perspective. There definitely is more awareness out there. And we're doing what we can as nurses to spread the word and get that awareness out there, provide that anticipatory guidance for all of these types of issues. Because children are just as susceptible to these problems as adults would be. Any questions so far, or anybody have any comments or anything so far? No? Yes? No? Okay. Thanks, Kay. Thanks, Renee. Thanks, Stephanie. I appreciate it. I like to know I'm not alone in here. Okay, so let's talk about what our role is. So obviously we need to obtain the history from the child and the family, and that includes medical history, any family history of any mental illness we would want to be aware of because that some of these can be hereditary, right? Conditions. So we need to obtain that. The history of when it first started, when they first started noticing these behavioral symptoms, or when things started to change, when they noticed a change. And it's not easy to talk about, but we need to use very calm, firm, and respectful approaches when we're dealing with these types of issues. They are very sensitive issues, sensitive for the child, but also sensitive for the parents. It's hard being the parent of a child that's having these problems. It really is, because you kind of feel helpless. What can I do? We want to protect our kids. We want to make sure that they have everything that they need. And when these kinds of problems surface, it can be you feel very helpless. You feel like, what do I do? I don't know what to do. So that's part of our role, is to provide that support for the parents and the child to demonstrate acceptance. We don't want to judge. We don't want to be judgeful at all, because that's not going to help us create that therapeutic relationship. And we need a therapeutic relationship with these types of issues. We absolutely have to have it. We can't do anything if we don't have a very strong therapeutic relationship, not only with the parents, but with the child as well. We absolutely have to have that. They have to trust us. They have to know that they can trust us. We have to prove to them that they can trust us. Okay? In our actions, in our words, okay? In the way that we behave, in our nonverbal communication. It all needs to show very open acceptance. Okay? These are very, very difficult subjects to talk about. They can be very embarrassing. They don't want anyone to know. A lot of times this gets hush, 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 hush. We can't talk about this, but we need to create an environment that they feel comfortable talking about it and that they know that they can trust us and that what they tell us is not going to go any further than us. We need to be focusing on their strengths and not only their problems because they do have strengths. So we need to focus on those strengths, not just the problems. Not that we don't want to talk about the problems. Obviously, that is part of the problem, right? Is that everything kind of gets brushed under the carpet and ignored and oh no, this is not a problem. We don't want to do that. But we don't want to only focus on the problems. We definitely want to be focusing on their strengths, the family's strengths, how they communicate with each other, how they interact with each other, and the child's strengths, how they communicate with others and how they interact with others. And we want to assist the child in developing coping mechanisms because that is a big issue is that these kiddos don't have either they don't have any coping mechanisms or their coping mechanisms are not very strong. So we need to help them in developing better coping mechanisms, different ways to deal with the stresses that they are under. Does that make sense for everybody? Does anybody have anything they want to add? Okay, that's fine. That's fine. All right, thanks guys. I appreciate it. I like to know I'm not by myself. Okay, so the last issue I was going to bring up is autism spectrum disorder, and not that this is super prevalent or very common, but it is something that I think we should be aware of as nurses dealing with families. We definitely want to have some awareness of this. Oh, I got a chat here. Hang on. These things disappear so fast I can't read them very fast. Stephanie says, biggest thing is to make sure you don't ever say, I know what you're going through. Oh, yes. That is so true, Stephanie. Thank you so much for bringing that out. We definitely don't want to diminish what they're going through. And though you might think telling them that you understand what they're going through is the right thing to do, it's not because we don't understand. We're not going through it. They are going through it. That's not how we show support. That actually diminishes how they feel. Just like telling them not to worry. Oh, please don't ever tell them not to worry. That you might think that you're helping, but you're not. That only diminishes what they're going through when you tell them not to worry. You can't tell them that. That's not being supportive. So thank you so much, Stephanie, for bringing that out. I do appreciate that. Thank you so much. Oh, yeah, it is very different. Everybody goes through these situations in a different way. And when I was going through my bullying situation when I was in grade school, I can't say that my parents were the best at handling it. I think they handled it the best that they could. But I can tell you now that I'm an adult and that I've been working with families for 30 years, the school did a very bad job of handling that situation. Terrible. My teachers, the principal, the social workers, awful, awful, awful. I can tell you that. It was bad. So I'm so glad that we that we do better than what we once did. I'm not saying we're perfect because we certainly aren't. It's always going to be a work in progress, but I think we definitely do better than we did. And I think there's a lot of peer support out there. There's a lot of kids out there that are providing support for their peers. And I just congratulate them so much that they're willing to stand up and say, you know what, bullying's not cool. It's not good. And we need to do what we can to help our peers and to get that awareness out there. And I'm so happy that the kiddos are taking that upon themselves. I think it's great. And I saw a chat. Hang on. Let me get the chat here. Oh, I had to change schools too, Natasha. My parents actually had to move to a completely different town. So I get you. I know. I had to do the same. Yes, it can be really bad. But, you know, I think we do the best we can. All right. So for autism, It's a very complex neurodevelopmental disorder with spectrum of behaviors affecting an individual's ability to communicate and interact with others in a social setting. Doesn't seem like a very, I don't know if it's the best definition, but it's the one that we've got. So that's what we're going to go with. The exact cause is unknown, but constant research, constant research, constant research. I know that there is a lot of research into this problem. So they must have a delay in at least one of the following cognitive functioning areas, either social interaction, social communication, in other words, interacting with others, or imaginative play prior to the age of 3. Okay. They become very distressed when their routines are changed. So I've talked about before that kids really like routine. They depend on routine. They want routine. These kiddos, it's essential for them to have their routines. When their routines are changed in any way, even the slightest way, it can be very distressing for them. And they don't have coping skills to be able to handle that change. They don't know how to handle it. And their emotions just kind of go through a whirlwind, right? And sometimes they can be very they can act out a lot, and it's, yes, Katrina, thank you for bringing that out. It is not caused by immunizations. There is no empirical scientific link between immunizations and autism. That is a misnomer. That is not true. So when we are working with families, when we are working with families in crisis, this is what I call families in crisis, when they have these types of issues, when they have ADHD type issues, depression type issues, cognitive type issues like with autism spectrum disorder. They're in crisis. And we have to make sure that they're getting quality evidence-based information, not hearsay. And there's a lot of celebrities out there, and people believe what celebrities say, right? Whether it be social media or whatever the case may be, people are going to believe what that celebrity says. And that's so sad because they don't always have the facts. A lot of times they say what they think, which is fine. I'm not saying that that's wrong. I think everybody should be allowed to say what they think. And, you know, if they have experience with their own families, that's great. That helps for support, right? That helps people realize I'm not by myself. But I don't think that it's right that they should be talking about things they don't know and don't understand. And they shouldn't be giving misinformation because people are going to believe it. And that's where we come in. We have to fix that. We have to make sure we're giving them the best evidence-based information. We absolutely have to. Okay. These kiddos can have delayed or absent language development, and they spend a lot of time alone because they really aren't good in social situations. They really aren't. And, you know, other kids can be afraid or maybe hesitant, reluctant to try to interact with these kiddos because they can sometimes be unpredictable. You don't know what's going to set them off in some cases. So they do spend an awful lot of time alone, which is very sad, which is very, very sad. And I know I got some chats here. Let me try to catch them. Oh, let's not talk about the president. Anybody but him. Okay. Okay. Yes, lots of myths, lots of myths, lots of myths. And actually, one physician um, talked about a link between autism and vaccinations, and that was later debunked. But the damage was done. Even though it gets debunked and the right information gets out there, it's out there. And that misinformation, there's a certain percentage of the population that are going to believe that misinformation no matter how many times you try to fix it. They're still going to believe it because a doctor said it. So there you go, you know, or a celebrity said it, right? Okay, so nursing care for these families and for these kiddos. We have to assist the family with screening assessment tools. It's very important because they need to get the screening done to get the appropriate diagnosis. Refer them for early intervention, either through physical therapy, occupational therapy, or speech and language therapy. That's going to be very, very important. Assist with behavior modification programs. That's going to be important. Promote positive reinforcement. We always want to stay positive and we want to have positive reinforcement. Increase social awareness. We have to do what we can for that. Set realistic goals. Please do. Don't be unrealistic in your goals. And it doesn't matter in what area you're setting those goals. Let's always make sure that we're being realistic. And structure opportunities for small successes, right? Small steps, baby steps. And let's focus on that accomplishment and let's praise them. Let's support them and empower them, right? And then we move on to the next step. It's really, really, really important with these types of issues, with any of these types of issues. It would be so important. Any questions, guys? I appreciate those of you that have been kind of either giving your opinions or talking about things that, your experience. I do appreciate that. That's how we learn, right? That's how we learn. We learn best from each other. Okay. All right. So let's talk about childhood cancer. It's not today's conversation's not uplifting, and I do apologize, and that's why I always save it for last, because this is not the most uplifting type of information, but it is important as nurses that we do have an understanding of it. So, what is it? Characterized by out of control growth and spread of abnormal cells. That's cancer pretty much in a nutshell. It can be caused by viruses or altered immunity, because our immune system, our surveillance, helps to prevent this from occurring. Chromosomal and or genetic abnormalities or environmental causes. Oh, most common childhood cancer is leukemia. Peak onset between the ages of 2 and 5. Let me see. I know there was a chat that popped up. Let me just see. Oh, let me go through here. Oh, my cousins. Oh, yeah. Yeah, I'm sorry to hear that, Stephanie. I really am. But that's the most common one is ALL, acute lymphocytic leukemia. That's the most common one that these kiddos get diagnosed with. But there's so much in the treatment now that they do that there really is a lot of hope. It's not the death sentence it once was. So there's so much hope, so much hope. And kiddos, I think they stand a better chance than adults do. I think in some cases, I think that they are more resilient in some cases than adults, and they do tend to go into remission more commonly than adults do. Okay, so what is our care? What are we responsible for? What's our role? Obviously, providing emotional support for the child and their family. Encouraging peer contact if it's appropriate and if it's applicable, if they're able to have contact with their peers. I mean, with our virtual environment now, as we've learned through this whole COVID-19 problem that we've been having for the last several months, there's virtual platforms that can be used so they can get that connection. They can have that contact with their peers, but they don't have to be face to face. So, because when they're undergoing certain treatments, their immunity is going to be down, right? So they shouldn't be in contact with a lot of other people because of the risk of infection. Pain assessment and management, right? We need to be on that. We need to make sure that we are monitoring and doing frequent pain assessments, that we are definitely using the appropriate scales depending on their age and their developmental status. We definitely want to make sure that we are managing their pain, because they will have pain and we want to make sure that we're managing it. Nutrition counseling is going to be so important to make sure, because they're going to be having side effects from the treatments, right? They're going to have nausea. They may have vomiting. Their appetite may be suppressed. So we need to make sure that we are providing the appropriate nutrition counseling for these kiddos and their families. Medical management education and support, right? When they're going through chemo or radiation or whatever the case may be, making sure that we are providing treatment to ameliorate those side effects and adverse reactions that they may have from that medical management. Provide support through the grieving process. One thing that we have to be aware of as nurses, as caregivers, we have to meet them where they're at. There is no right or wrong way to grieve. There is no, okay, it's been 6 months, you should be over this by now. That they could be in the denial phase for years. I mean, it's appropriate. However they grieve is appropriate. We're not there to judge. We're just there to provide that support and that empowerment and to answer any questions that they may have and to help them with that grieving process. I mean, this is a child, right? This is their child. This is their loved one. This is their brother or sister that is going through this. And there's no right or wrong way for them to grieve. Okay. We need to be part of the preparation for the child and the family for that death, going through that dying process. It's difficult, especially when it's a child. It's so difficult when it's a child. And I have been privileged to have helped children and families that have gone through this process. And I consider it a privilege. I consider it a privilege that I was there to be able to provide that support and to be that sounding board if the parents just needed to lash out. And I was the sounding board and I was okay with that. I felt privileged to be able to do that. And I provided them with as much support and empowerment as I possibly could. And for the siblings, because it's difficult for the siblings, there may be a little bit of jealousy there. How come this kiddo is getting all the attention and nobody really pays any attention to me anymore? And that may seem, oh wow, that's kind of selfish, but is it? No, it's not. It's part of their process and it's okay. And we need to let them know that it's okay to feel that. It's all right. We're here to help. We're here to provide support. We're not here to judge. We are never there to pass judgment. We always want to be supportive. We always want to be encouraging. We always want to be empowering. Any questions, guys? I saw something in the chat. I'm really trying hard to keep up with this today because you guys are really putting some great, well, sometimes they don't know any better. You're right. You're right. Oh, your cousin had another child? Oh, but 10 years of remission, that's great. I mean, that's really, really good. That's great. That's really great. That's really great. Thanks for sharing that, Stephanie. Thanks for sharing that. Okay, guys, any questions? That's about it for our time together today. No questions. Okay. Thank you so much for coming. I do appreciate it. I do appreciate it.
I actually have a quick question. Sorry.
Okay.
I know next week we don't have class
We
because
do not.
Labor Day, and then the
Yes.
following week is the final. Are you
Mhm.
going to do a final review or anything like that, or no? Just curious.
I'll have to take a look at the calendar to see when I can schedule it. Because I'm not exactly sure if I'll be able to schedule it. It really
Okay.
depends. If I can, I'll try to do one next week, maybe Tuesday or Wednesday. Because with you guys with your PN2 schedule, that makes it hard too. Because I don't record reviews.
Yeah.
I don't
Well, we're
record those.
done this week.
So,
Is our last week of PN2 clinicals.
oh, okay.
So that
That's
those are
I'll
done next.
see what I can do then.
Okay, and then but there will be. I guess my other second part to the question was there will be more information in the next module, though, right? Even though we don't have live class, there's more covered than just this, right?
Yeah.
Yeah.
Peds
Yeah,
trauma
they'll
and
be
critical
recorded.
care.
Okay. Yeah. All
Yeah.
right.
Yep.
Okay. That's
There will
it.
be. Okay. Thanks, Jen. All right,
And
guys.
tests will be posted by morning, probably. Same thing with
Well,
respondent.
Mondays is a very high respondus usage day, so it does take time for the exam videos to process. So that would be my assumption, but I always check. You never know. But it can take up to 24 hours for those to process, yes. Okay, I'm going to stop my recording.